Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 19, Mind and Body. Attitudes to mental health have undoubtedly changed over the course of my career. The idea of treating physical health with minimal reference to mental health is outdated, but it's not yet a thing of the past. I once went to a maternal mental health conference and heard a woman speak about her experience of pregnancy and childbirth as a woman with a significant mental health condition. And she put up a picture, and the picture was of a headless body. And that really affected me. The idea that we were treating her body and not her mind, and that her head was completely left out of the equation, was very difficult for me to contemplate. Mainly, I think, because it's something I recognise. I recognise that happening. So it's a little bit of a heart sink moment. My interest in women's experience of maternity care has inevitably meant that women who want their thoughts, their feelings, and their mental well-being to be really thought about and really heard sort of gravitate towards me. And that's not to say that my colleagues don't look after these women and look after them exceptionally well. Of course they do. But I know that sometimes they feel frustration that their antenatal clinic is being taken over, not by obstetric clinical diagnoses, people with what they would see as genuine obstetric clinical problems, but with what can sometimes be termed the worried well. And I don't want to be dismissive. I've used that phrase myself in the past. But the more I explore women's feelings and women's mental health, the more interesting I find it, and the more links I find and the more complexity there is between the way our mental well-being affects our physical well-being and vice versa. Some of this actually inspired me to write a poem. We were just starting in 2018 a project called MindNBody, the same as this podcast episode is called. It had been very clear from the beginning of the maternity experience work I was doing that we needed a whole project on maternal mental health. And we were very fortunate in that London, the West Midlands and South West England all joined together to fund a project. And as we were starting that work and starting that project, I wrote the following poem. Reassured. It's written in my notes, so it must be true. But is that reassurance for me or for you? You may have the power of writing, but how can you know the demons I am fighting? The symptoms that plague me, the worries that assail me. All normal pregnancy, you say, and dismiss them away. Let's get back and focus on the clinical, the physical. You try and be kind, but inside I can't stop the whirlwind that is my mind. And part of the reason I wrote that poem is it was quite commonplace for me and many other clinicians to write reassured in the notes. So women would come and tell us about whatever problem they would have, and we would talk to them, and then we'd write reassured. Without really knowing, had we reassured that woman or had we not? We hadn't asked her if she was reassured. We'd attempted to reassure her, but we had no idea whether that was actually effective. And I must admit, since writing this poem and doing that project, that isn't something I write in the notes anymore. Part of the reason we need to consider perinatal mental health is that it has a profound impact, not only on the woman, and sometimes in a very significant way. We have to recognise that maternal suicide remains one of the commonest causes of maternal death in the UK when we look at the Embrace reports. But it also has a profound effect on the development of the infant. There's much focus on the first 1,000 days, the first 2 years of life, and from conception to 2 years of age. And we know that maternal well-being and maternal mental health definitely has an impact on the developing brain of the baby and infant, and how its development and mental health and well-being develops as it grows up. The other reason this is really important is mental health problems are increasingly common. In the last year, in my maternity unit alone, my hospital alone, 17% of women have had some sort of mental health history or issue at booking. That's huge. That is 900 women. It's a very frequent issue, and we need to be sensitive to it, whether it's declared or not declared. If it's not declared, we need to pick up on verbal cues, pick up on body language, pick up on eye contact, how that woman's talking, and ask her, does she feel well in herself? Women need correct information. I often see women in early pregnancy who've stopped taking medication. So they may have been on medication for anxiety or depression and then abruptly stopped it at the beginning of pregnancy. And that might be at their own instigation. Sometimes it's misinformation. They've been incorrectly told by another healthcare professional to stop it. And as many people are probably aware of, if you stop an SSRI antidepressant abruptly, that actually can be extremely dangerous. There's been a lot written about how difficult it is to come off those sorts of medications. And actually that coming off them can increase symptoms of anxiety, and women can have significant withdrawal symptoms. So abrupt stopping of medication when someone realises they're pregnant is potentially very harmful. Women really don't like taking medication in pregnancy, and sometimes this is an issue when a woman gets a new condition in pregnancy, a new mental health condition. It can be extremely difficult to persuade her to take medication. A woman will take medication if she breaks her leg, but she won't take medication for something that she sees as mental health. So sometimes we're caring for women that we can see have very significant mental health problems, but they don't want to comply with what we're recommending, or they don't want to take it until after they've had their baby, even though we give them assurances that it is safe and it is safest for them and their baby that they get treatment. Maternal mental health care in my area has been very disjointed for a very long time. It was very difficult. We had to rely on liaison psychiatry, which are the only on-site psychiatric service, and then referral to the community mental health trusts. And because of where my hospital is, we might link to 5 or 6 community mental health trusts. I appreciate that's partly because we're a London trust, but it makes it very difficult that the first thing you have to think about when you have an unwell woman is where does she live and which mental health trust might she be under depending on her postcode. Sometimes this would lead to difficulties with referrals, only to spend a long time referring to one place to discover actually you should have referred to another place. It's quite a fractured service, very disjointed, and we introduced specialist midwives to help literally bridge the gap between primary care, GPs, community mental health trusts, and secondary care in the maternity unit. Fortunately, this gap has been recognised, and after many, many years, through the National Maternity Review in 2015, maternal mental health became a priority. And now we have investment in the service like we've never had before. Most of this investment is surrounding the women with moderate or severe illness. But it is true that there is also increasing support of IAPT, so that's psychological talking therapy, availability for women. And women can self-refer into this. And we've built links with these local services, so we know we can tell a woman to self-refer in, and that service will assess her rapidly and either start some treatment or recommend what she needs or send her on to the more significant perinatal mental health service if actually her illness seems more severe. We've also got adjuvant things we can suggest, such as wellness, mindfulness and yoga, although obviously that's been a lot more challenging during COVID. And the other thing from the National Maternity Review that I think is going to make a huge difference is continuity of care. If a woman knows her midwife or knows her team of midwives, it's much easier to confide in them how she's actually feeling, what's troubling her, what her issues are, what her home situation is, because she knows them and she's built that relationship and trust. And if those same midwives are going to look after her throughout pregnancy, birth and postnatally, that's just brilliant. They can see her all the way through and really provide that personalised support that's so needed. Turning now to more the tip of the iceberg, women with more severe illness, we have been fortunate enough to have this service grow and develop in the last 18 months or so. And because of my interest in women's experience of maternity care and the fact that I was already seeing a number of women who had tocophobia, fear of childbirth, or previous severe postnatal depression, or birth trauma, PTSD, it seemed a natural fit for me to become the lead consultant for perinatal mental health. And it's been a complete joy to help develop the service. So about a year ago, we started our joint clinic. So we have an antenatal clinic in which we have the specialist mental health midwives, myself, and the psychiatrist who is leading the perinatal mental health team. We can see women jointly, particularly at 32 weeks, we often have a joint appointment for pre-birth planning. But it also means if a woman's coming to see the midwife and needs to drop in and see the psychiatrist, she can. If she's seeing the psychiatrist and actually she needs an opinion from me as the obstetrician, she can do that too. We're all there every week in clinic together. So every week I can talk to my consultant psychiatric colleague about upcoming patients. Every week my psychiatric colleague can check with me. We're not sure what's happened to this woman. Has she had her baby? Has she got any upcoming appointments? Which team of midwives is she under? We've seen some incredibly complex cases over the last year together. And not only are we being able to wrap that service round that woman, but wrap it round her family. So at the pre-birth planning, we usually have the woman's partner, plus any other member of her family she feels is important. We have the perinatal mental health nurses, psychologists, occupational therapists, nursery nurses. We have every aspect of care within the team. Health visitors and social services, obviously, where necessary as well. So we can make really thorough plans that give women confidence as they're coming up to their birth and that first few weeks with that baby. And because the perinatal mental health service lasts for up to a year after birth, they know they're going to see the same team after the end of pregnancy and through that first year of their baby's life. I find it an absolute joy to be part of such a service. And the feedback we've had from women is fantastic. The other thing that's been really good is to have trainees, junior doctors, come and join me in the clinic. So when we have a GP trainee, I've often managed to get them to sit in with my perinatal psychiatric colleague. Some of the junior obstetric doctors too can come and listen and learn about perinatal mental health in a way that there just wasn't opportunity before. So hopefully we're starting to train and inform the next generation of doctors and midwives, as well as providing a great service for our patients. It's been more stressful during coronavirus. There was a little bit of difficulty when the mental health team were being asked to work from home and switch to virtual consultations, and yet we as obstetricians and midwives were still seeing people face to face, and that was a little difficult. And in the end, actually, we've kept the joint clinic going throughout with obviously appropriate protection. But I think that's been important because coronavirus has inevitably been a difficult time, increasingly so for patients with maternal mental health conditions. The junior psychiatric doctors during COVID started a COVID newsletter to help support women under the care of the team. And this reiterated how to access help during the COVID crisis, ways that they could reach out of the home during complete lockdown, ways they could access help, things they could do to keep themselves safe, confident and comfortable during such a worrying time. And they went through a whole range of different topics and were really useful to give out in the antenatal clinic or be emailed out to those people under our care. There's quite a lot of peer support out there. So I know there are lots of endeavours, lots of women up and down the country who've experienced perinatal mental health problems, who want to support other women during their time of need. And sometimes having peer support is really beneficial. It's that trusted friend so that they don't feel alone, so that they don't feel that there is this veneer of perfection of motherhood and that actually you can't talk about how you're really feeling, what's really going on, and that actually you might not be overjoyed to be pregnant or have this new baby, and that you need to explore those feelings in a safe space. I'd love to talk in lots of detail about all the various groups and individuals I know about, but there are so many that I just feel I might leave someone out in error and offend them. So perhaps at the end of the podcast, have a little look at the MatX hashtag and you'll pick up and see some of the brilliant things that are going on up and down and around the country. I've talked quite a lot about common things, the large proportion of women who have some sort of mental health history. And I'm now going to turn my attention to the uncommon things. Postnatal psychosis. Postnatal psychosis is rare. In my whole career, I've seen it less than a handful of times. It can be difficult when it's rare and we might not even see one a year to recognise it. And it's very important that we do recognise it and get that woman help very quickly and efficiently. It's a very significant mental health illness. It is extremely treatable. And once you've seen it as an obstetrician or midwife, I would say you would recognise it again. The first time I ever saw it was in a woman I'd seen antenatally, and so it was really easy to see how differently she was behaving and how different her personality was. It was like she'd become a completely different person. Often women are extremely restless, can't settle, can't sleep, very restless, quite paranoid behaviour, quite delusional, often feel staff are trying to do something to them or their baby. And it can be quite difficult if you don't know what you're dealing with. It can be quite frightening, and it can be difficult because you can't really reason with her. And I think the people it's really frightening for also is partners seeing their wife totally transform, totally change, and be totally unable to reassure them. Of course, it will often happen at a night, at a weekend. I've had at least 2 cases happen at periods over Christmas, when of course you're on perhaps less staff, less expertise, difficult to deal with. And one of the cases I have had, the first port of call is liaison psychiatry, because they're actually available and on site. And I find it really difficult as a consultant obstetrician when a very junior liaison psychiatrist tells me that there's nothing wrong and that it's simply sleep deprivation. And I have to stand my ground and say, no, absolutely not. This is psychosis. As I said, it's treatable completely. And sometimes it can be treated in the maternity unit and then at home with a home treatment team. Sometimes it requires hospitalisation, and if it does, ideally we want that woman to go to a mother and baby unit, because then they can treat the mother and keep her with her baby rather than separating them, which is what happens if a woman has to go to an adult mental health ward. An adult mental health ward, as you can imagine, is really not the place to be when you've just had a new baby and you're in the grip of this terrifying illness, and you're already feeling quite paranoid about what people are or are not doing to your baby. But mother and baby units are far and few between still, and although new ones are opening and although things are improving, there still could be much more capacity. When we get a woman into a mother and baby unit, it feels like a massive relief, huge relief, and it's always a struggle. Even now, even with all this national investment, it's a struggle. And so when a woman goes there, it's like a weight off my shoulders, a big relief. So it's really important in the thick of all the goings on in a maternity unit to pick out and recognise those women with severe mental health problems and treat them appropriately, not only for them, but for their baby and for their family. So I know I've barely scratched the surface, and maybe mental health, almost certainly mental health, will be something I'll come back to in a future episode. But that's a little thought introduction for today. Now it's time for the zesty bit. The zesty bit this week is about education. Educate yourself in perinatal mental health, in your training, in your continuous professional development. It's so commonplace. And we can have experts, So we can have our specialist mental health midwives. We can have support from our specialist perinatal mental health teams. But actually, we all need to be expert in maternal mental health. As expert in that as we are in physical. So if you have an opportunity to go and sit in a perinatal mental health clinic or talk to those that work in one, go. Read women's accounts. There's some fantastic stuff online. What people have written about postnatal depression, postnatal psychosis, and all sorts of other things. Birth Trauma Association and so on. Read widely. Make yourself an expert in maternal mental health as much as you are in maternal physical health. If you're a pregnant woman, trust us. Trust us to talk to us. Talk to us about how you're feeling, whether that's in the antenatal period, having your baby, or postnatally. No, you are not alone. It's common not to feel overjoyed. It's common to feel low. It's common to feel mood swings. It's common to have doubts and problems. It's a major life-changing event. Trust us. Talk to us. Access help. And for all my listeners, if you're interested, perhaps take a look at some of the videos that we produced at the end of our MatX Mind and Body project. I'm putting a link in the programme notes. It's an amazing array of videos of people who participated. Pregnant women, health professionals, all sorts of people who participated in pooling lots of real life, lived experience scenarios of maternal mental health in the UK. So I do hope you've enjoyed listening to the obspod. If you have, do like, subscribe, or leave a review, and join me again to explore more about the life of an NHS obstetrician. I'm finding it really exciting to have people listening and give me feedback about what they've found interesting. So please do recommend the obspod to other friends, colleagues, or people who you think might find it interesting. I'd love it if you'd share with me what you've enjoyed about listening and if you've done anything differently as a result. I can be found on Twitter at FW Maternity and at theobspod. And please do check the MatExp hashtag MATEXP, and the website matexp.org.uk for more information and ideas on how to improve women's experience of maternity care. Finally, I'd like to reassure you that I take confidentiality very seriously, and although I'm talking about experiences from my working life, I'm taking great pains to make sure that I anonymise the stories and talk in more general terms so that I keep confidentiality of my women I currently care for and have cared for in the past very safe. Many thanks for listening.